morning, respected dignitaries, teachers, and my fellow colleagues. Today, we'll be discussing a case of 28-year-old male who presented with complaints of palpitation, diarrhea, and agitation. Department of Endocrinology and Department of Nuclear Medicine will be working in unison with us. 28-year-old unmarried male studied till 12th class, mechanic by occupation, resident of Alwar, was brought to psychiatry OPD by his sister, who also informed his history and is a reliable source. The patient came with chief complaints of loss of weight despite increased appetite, increased perspiration, tremors, diarrhea since 1 month, decreased need of sleep, overtalkativeness, aggressive behavior, suspiciousness, and hearing of voices since 15 days. Mode of onset was acute for psychiatric complaints. The patient was apparently alright 1 month back when he started experiencing an incessant urge to eat. He was having 2 to 3 meals. The patient was apparently alright 1 month back when he started experiencing an incessant urge to eat. He was having 2 to 3 meals a day and had started consuming 5 to 6 meals a day, which was a significant change from previous diet. Despite the increased appetite, his weight was decreasing over the past month. It was undocumented, but his attendants informed that the patient's clothes had become looser by 2 to 3 inches. Patient also shares of noticing excessive sweating more than his usual self, occurring also when he is not doing any activity or is at rest, along with fine shivering of hands were noticeable at fingertips, which occurs at intervals throughout the day and resolves spontaneously over a couple of minutes. Patient also shares of increased frequency of loose consistency stools, which were 2 to 3 in the beginning and gradually progressed to 3 to 4 per day. For the past 15 days, patient had also been complaining of sleeping only 2 to 3 hours per night and had decreased need for sleep. He would roam around at the house at night and would often have a quick bite of whatever he could find to eat. He spent long hours working at his garage, but was unfocused and less productive than normal. He would sometimes fumble with basic repairing work and would switch from one task to another. He also started talking to people who were not known to him and were not interested in having a conversation with him. It was difficult to interrupt him. He was aggressive without any provocation. He would hurl abuses and even showed violent behavior towards people who disagreed to his thoughts or interrupted his actions. He had grandiose ideas that he was born with special abilities and power, which were possessed only by him, as he was the chosen one and was sent to earth for a higher purpose. He also stated that he could listen to God's voice guiding him to pursue his mission on earth. He started reporting that people around him are getting jealous of him and he was mistrustful of everyone around him. They were trying to harm him because of his special powers and uniqueness. Past history. There is no history of any medical illness or treatment in the past. History of an episode a year back where he had decreased need for sleep, over-talkativeness, over-grandiosity, over-familiarity, inflated self-esteem. He gradually became symptom-free within 2 to 3 months without any treatment. Family history. The patient had no history of any psychiatric or medical illness in the family. Personal history. Personal history is an integral part of psychiatric history. It comprises of chronological account of person's personal experience starting with his birth. The predominant emotions associated with different life periods are mentioned in personal history. Birth and early development, home atmosphere in childhood, school and extracurricular activities, occupational history, marital history and sexual history are a part of personal history. As in our patient, his early and birth and early development history could not be elicited because his parents weren't present during the assessment. The home atmosphere was strict and there was critical parenting. He studied till 12th class in a Hindi medium school and dropped out of studies to take responsibility for the family. Premorbid personality. Premorbid personality is an individualized style of dealing with the environment that is characteristic to each person prior to the onset of psychiatric disorder. This is an integral part of psychiatric history, and it is considered in broad categories of social relations, intellectual activities, the character of the person, attitude towards self and his work, and his interpersonal relationships. In our patient, he had good interpersonal relationships, he was extrovert and cheerful, enthusiastic, his energy levels were high, but he was intolerant to frustration. General examination. At time of examination, the vital parameters recorded of the patient are as follows. Noticeably, his pulse rate was 140 beats per minute and blood pressure was 140 by 70 millimeters of mercury. On general examination, he appeared thin and underweight with excessive sweating throughout the examination, and his facial expressions were visible. Pallor, icterus, clubbing, cyanosis, edema, lymphadenopathy were absent. His skin was warm and moist. There was a diffuse swelling present on the neck, which moved upwards while swallowing, of regular consistency, firm, no nodules or mass were palpated. Eye examination, mild proptosis was present. On systemic examination, in cardiovascular system, tachycardia was present. In central nervous system, the reflexes were brisk. Mental status examination. Mental status examination is the psychiatrist's version of physical examination. It is defining status of the current state of patient during evaluation. It thoroughly captures the objective and subjective aspects of mental illness. It's divided into broad categories as follows. Appearance, behavior, psychomotor activity, speech, mood and affect, thought, perception, insight and judgment. It also includes higher mental functions. Coming to our patient, he was conscious and alert. Upon greeting him, he initiated eye contact, but frequently shifted his gaze away from the examination. The patient was poorly groomed. Facial expression suggested that he was distressed and irritable. He was agitated and hurling abuses at the attendants and other patients there. His attitude was frank and rapport was established easily as he started complaining about his attendants to the examiner that they were not letting him leave and that he had to go fight a battle. This is the motor behavior. His motor behavior throughout the interview was restless. He was constantly fiddling and shifting on his chair. He could not sit still and was constantly standing up and sitting again. His speech was loud and hoarse with increased pitch, decreased reaction time. Productivity of the speech was increased and was difficult to interrupt, although the speech was understandable and relevant to the questions asked. Mood. This is a patient's subjective description of how they are feeling. It is determined by directly asking the patient to describe how they are feeling. So on inquiring, our patient replied, "Bahut hi badhiya." Affect. This is how a practitioner describes patient's observed expression. The patient's affect was labile, alternating between elation and irritability. He had an increased sense of well-being, general overactivity and disinhibited behavior. Mild interruption or provocation led to irritability and poor control over aggressive impulses. Thought. The flow of thought was rapid and increased in amount, and there was uncontrollable excessive talking which was difficult to interrupt. Form. The patient was able to communicate verbally adequately. There was no unrelated or unconnected ideas shift from one topic to another. Possession. The patient recognized his thought as his own. Content. On analyzing his thought, it was found that he had delusion of grandiosity. But what is a delusion? Delusions are firmly held false beliefs of a patient which are not part of cultural belief system and persist despite contradictory evidence. Delusion of grandiosity. The patient believed that he has unusual talents and was more powerful than anyone else. The patient believed that he was the chosen one by God and was sent to earth for special mission with supernatural powers. According to him, his mission was to eradicate all evil from earth. Delusion of reference and persecution. Delusion of reference is unrelated occurrences refers to a patient, and delusion of persecution is when someone is convinced that someone is conspiring against or planning to harm the patient. In our case, the patient believed that people present in the ward were talking about him as they were jealous of his superpowers. The patient also had paranoid ideas that the hospital staff was trying to harm him so they could stop him from accomplishing his mission. These referential and persecutory ideas were present secondary to his delusion of grandiosity. Perception. Patient had auditory hallucinations. Hallucination is a perception of something in the absence of an external stimuli. The patient reported that he could hear voice of God guiding him to pursue his mission on earth, and he and only he could fulfill God's will on earth. Attention and memory. He was easily distractible with a short span of attention. His judgment was impaired. Insight. He had grade 1 insight with complete denial of illness. Now I'd like to call upon Dr. Anubhuti Sharma ma'am.
So now we have seen our MSc and history in details. Now I would like to summarize all of this. Our patient is a 20 years old unmarried Hindu male, having complained of loss of weight and increased weight since 1 month, increased sweating since 1 month, and tremors, diarrhea from last 1 month, disturbed sleep, over-talkativeness, aggressive behavior, suspiciousness, and hearing of voice since last 15 days, and also having a positive past history of similar illness. And his mental status examination is like psychomotor activities are increased, pressure of speech is there, and delusion of grandiosity and persecution is existing. His orientation is intact, and judgment and insight is impaired. On the general physical examination, we observed that hypertension and tachycardia in warm and moist skin and diffuse swelling in neck and mild proptosis was there, and reflexes were exaggerated. So, can you please suggest any psychiatric differential diagnosis or organic differential diagnosis? So actually we have to see both the things, general physical examination and mental examination. Abnormalities are seen in both of examination and history as well. So compiling all of this, we'll go for a differential diagnosis. So let's discuss psychiatric differential diagnosis. Our first differential diagnosis is obsessive compulsive and related disorder. So we can see in history and MSc as well, there is no repetitive acts or any compulsive activities were there. So, of course, this is very unlikely. And when we come to the delirium, there is no fluctuating level of consciousness or sundowning phenomenon is there. As we already told that orientation was completely intact, so it is also very unlikely. And when we talk about the schizophrenia, as you told, and schizoaffective disorder, two major things are there in this case. There is no, and duration criteria has been not fulfilled, and this is no interrupted illness. As schizophrenia is a continuous and uninterrupted disease that leads to problem in cognition as well as perception, thoughts, hallucination, delusions. Of course, these are there, but these are not so bizarre, and continuous illness is there, and mood is elevated in this case. But in schizophrenia, mood elevation is not there. But when we talk about schizoaffective, we can see mood disorders. But this is uninterrupted disease. It's only 1 month criteria has been fulfilled. So these both. Yes, sir. No, sir. In DSM as well as ICD, according to DSM, we need the criteria for 6 months, and when we talk about ICD, it should be more than 1 month. So these both diagnoses are also very unlikely. And when we talk about substance-related disorder, in history we saw no substance was there. In urine test also we saw there was no any cocaine, cannabis, or any kind of substance was we can found. So it is all. So urine tests are there, sir. Laboratory tests we can do. So if we suspect, sir. Yes, sir, we can do, sir. So if we are suspecting, so we are doing, sir. So the patient is telling I am taking, sir, then we don't go for that. Now let's talk about bipolar disorder, and if we talk about
how many times have you found that the patient may be taking or is taking but doesn't reveal that history? How would you suspect? If I don't tell you I am taking a drug, how do you suspect that I am taking a drug?
Sir, withdrawal symptoms. Sir, some withdrawal symptoms are very specific.
Withdrawal you would know only if he would say that he is not able to take it. If I don't reveal the history that I am taking drugs, how does a psychiatrist suspect that the patient may be taking something?
Sir, if someone is consuming any substance, sir, there are some symptoms we can see that should be present in the patient. Sir.
That is what I am asking.
Yes, sir. If patient is taking cannabis, so we can definitely see that tightening of eyes is there, he's consuming more food, he's more, he's some bizarre behavior he is doing, sometimes he would be confused. So there are specific symptoms for specific substances, so he can suspect about that.
So in this case, you did not suspect that he is taking?
No sir, history was not there, as well as in urine analysis we could not find any substance. So when we talk about bipolar disorder, we can see elevated mood was there, increased goal-directed activity was there, and as well as delusion of grandiosity and persecution both were there, so we could not rule out this diagnosis. Now we will discuss upon organic causes. So I would like to request, can anyone suggest any organic causes? Okay. Anyone else? Okay. Anyone else? Okay, fine. Let's move. If we talk about CNS causes, we can suspect Wernicke's aphasia, complex partial seizure, narcolepsy. And we talk about nutritional deficiencies, of course vitamin 12 deficiency, it is very common, and iodine deficiency as well. And coming to the metabolic causes, Graves' disease and thyroiditis is there, so still we could not rule out it. And when we talk about autoimmune disorder, SLE we can suspect. Infective disorder, HIV as well as neurosyphilis. So now we will be excluding our diagnosis, and we'll come to our diagnosis now. And when we talk about Wernicke's aphasia, Wernicke's aphasia has some presenting feature, like patient cannot comprehend whatever we are talking, and patient as well as can't repeat it, because that is the area that is responsible for comprehension. But we can see patient can comprehend, so we can rule out this diagnosis. And when we talk about complex partial seizure, in complex partial seizure it is very normal to have a aura, automatism or any confusing episodic violence. We could not keep these symptoms also, so we could not consider this as a diagnosis. When coming to the narcolepsy, there is no tetrad of excessive daytime sleepiness, cataplexy, sleep paralysis and hypnagogic hallucination. So that is also very unlikely. And when we come to the nutritional deficiency, vitamin B12 deficiency, for vitamin B12 deficiency, we went for the investigation, we could not find any deficiency in vitamin B12. And when we talk about iodine deficiency, so it is very rare because our salt is already fortified with iodine as well. Now coming to the infective disorder, on testing HIV we found negative test, and in neurosyphilis, as we know, it is very, very uncommon nowadays, and the symptoms like seizures as well as headache, nausea, vomiting, neck stiffness, photophobia we could not found. So these all diagnoses were also very unlikely. Now coming to the autoimmune disorder that we can consider SLE, we could not found any skin lesions, so we can rule out it. And when it comes to the metabolic causes, that may be Graves' disease or thyroiditis, so we could not rule out the diagnosis. Now coming to the management part, on the day of admission, the patient was very much aggressive, assaultive, restless and violent. So we admitted the patient at male psychiatric ward in a separate isolation area. As delusions were there, sleep was decreased and increased appetite was there on examination. BP was 140/70, pulse rate was 140 beat per minute, and respiratory rate was 24 per minute, and temperature was 98.3. We can see it is increased. The following investigation we sent CBC with ESR, serum electrolytes, RFT, LFT, thyroid profile and C-reactive protein. As we can see, the patient was so much assaultive, so we have to manage the patient on day first. We gave him tablet sodium valproate 500 mg per oral BD basis, quetiapine 200 mg per oral BD basis and lorazepam 2 mg per oral on BD basis. And we also gave injectable haloperidol promethazine on the state basis to make the patient calm and to make him sleep, and on SOS basis as well. And we sent the investigation and we got the report. The reports, investigations are following. So as we could see, T3 and T4 is apparently increased. hepatitis C is not reactive, hepatitis B negative, and HIV 1 and 2 antibodies were not non-reactive. So as we can see, there is an apparent increase in T3, T4 and decrement in TSH. So the endocrinology reference was done since investigation showed different values in thyroid profile. I would like to, we took endocrinology reference was done in investigation. Now I would like to call Dr. Jyoti Sharma from Department of Endocrinology.
Good morning, respected teachers and my dear colleagues. As I have rightly said, the patient was having dietary features of thyrotoxicosis. Still, I would like to summarize the history of 28-year-old man presenting with palpitation, tremors, diarrhea, agitation, loss of weight despite increased appetite, and features of irritability, hyperactivity, irrelevant talkativeness, and disturbed sleep. General examination of skin, neck has already been described. On examination, mild proptosis was seen, lead leg was positive, extraocular movements were normal, and clinical activity score was 0/7. This score is used to see the activity of the eye disease. In case of CNS examination, higher mental functions has already been discussed. Exaggerated DTRs were there, rest of the CNS was normal. Cardiovascular systemic examination revealed hyperdynamic circulation in the form of tachycardia, bounding pulses, white pulse pressure, hyperdynamic precordium, loud S1. Rest of the systemic examination was normal. So, 28 years old male with palpitation, weight loss, increased appetite, tremors, agitation, diffuse goiter, mild proptosis, and features of hyperdynamic circulation, all suggestive of thyrotoxicosis. And as expected, investigations reveal highly elevated T3, T4 and suppressed TSH. So in case of thyrotoxicosis, the etiology can be broadly divided in under two categories. One is the increased production of the thyroid hormone, which we call hyperthyroidism, and the other one is the increased release of the preformed hormone known as thyroiditis. Most common cause of hyperthyroidism is Graves' disease, seen in 60 to 80% of such patients. So these are the points of differentiation between both the condition. Thyroiditis is short in duration, mostly self-limiting, while treatment is required in case of Graves in the form of anti-thyroid drugs, RA ablation and surgery. Goiter and eye signs are present in Graves. Thyroid scan and uptake shows increased uptake in Graves, and TSH receptor antibodies are positive in case of Graves. So then we ordered a thyroid scan and we have sent TSH receptor antibody as well, but the report comes after a few days. So the thyroid scan and uptake report will be discussed by Dr. Shubham from nuclear medicine.
Thyroid scan was ordered for this. Good morning, all the respected faculty members. My thyroid scan was ordered for this patient. In thyroid scan, we look for functional status of thyroid, either it's a hot nodule or cold nodule. Or we try to look for any ectopic thyroid tissue if present, or we look for the differential diagnosis of any mediastinal masses, that is the RE 123. And when we look for percentage uptake of technetium, we look for differential diagnosis of thyrotoxicosis. We calculate dose of iodine 131, which is required for the treatment of Graves' disease. And for thyroid cancer, we look for we do whole body scan, we do a pre-therapy scan, post-therapy scan, follow-up scan, in which we quantify residual and recurrent diseases. So by this mechanism, follicular cells of thyroid gland take up iodine and converts it into iodine, and which is further organified to monoiodotyrosine and diandotyrosine, and further converted into T3 and T4 in follicular cells of thyroid and released into peripheral circulation. This is our department's hot lab, in which we have a fume hood, a technetium generator, and this is a red collier in which we carry technetium pertechnetate, which is a radioactive source to the patient. And this technetium generator is a molybdenum technetium generator is received under the regulation of Atomic Energy Regulatory Board once in every 2 weeks. So technetium pertechnetate has chemical properties same as iodine and is taken up by same mechanism as iodine. So it can replace iodine for the thyroid scan. It is not organified and retained in the thyroid. Imaging is performed early at a peak uptake time of 15 to 30 minutes after injection, and the lack of particulate emission and short half-life results in reduced radiation dose to the thyroid. When we look at the percentage uptake of technetium pertechnetate in the thyroid gland, increased uptake is seen in Graves' disease, autonomously functioning thyroid nodule, multinodular goiter, hashitoxicosis, hydrochloriform mole, and trophoblastic tumors. Metastatic thyroid cancer sometimes can also show increased uptake. Decreased uptake is seen in various types of thyroiditis and amiodarone-induced thyrotoxicosis, iodine-induced thyrotoxicosis, and stroma ovary. So this is a thyroid scans of some patients done in our department. This is a normal thyroid scan. This is thyroid scan of multinodular goiter. This is of thyroiditis, and this is autonomously functioning thyroid nodule. Particularly talking about this patient, diffuse symmetrical uptake was seen in both the enlarged both lobes of thyroid gland, and there was no evidence of any pyramidal lobe or retrosternal extension. Total 15% of the tracer injected in the body was taken up by the thyroid, and 7.6% of which was taken by right lobe of thyroid gland, and 7.4% was taken up by left lobe of thyroid gland. These scan features are suggestive of diffuse toxic goiter, for which one of the potential treatment therapies is radioactive iodine ablation. This is according to ATA guidelines, recent ATA guidelines, in which suggest that different modalities of treatment according to clinical situation of the patient having Graves' disease. And in patient with Graves' disease, radioactive iodine ablation is a preferred therapy in patients with increased surgical risk. If patient is having any liver dysfunction, adverse reaction to any antithyroid drugs, any congestive heart failure, pulmonary artery hypertension, elderly with any comorbidities, but pregnancy is a strict contraindication, and lactation is a relative contraindication for radioactive iodine ablation. Now I would like to call upon my senior Dr. Jyoti Bose to throw further light on the treatment.
So our patient has increased T3, T4, decreased TSH, thyroid scan showed increased uptake, and his TSH receptor antibody also came out to be highly positive. We started him on beta blockers for sympathetic management. Anti-thyroid drugs in the form of carbimazole was started simultaneously. On this treatment, patient improved gradually over next few weeks. His tachycardia settled, appetite normalized, diarrhea decreased. Now such patients, further treatment, we prefer to give anti-thyroid medication for about 18 months, because by that time 50% of the patients of Graves' disease goes into remission. For those who do not, the definitive management is radioactive iodine ablation, as Dr. Shubham has mentioned. In some patients, when there is a very large goiter with compressive symptoms, surgery can also be done. So to discuss the psychiatric management, I now invite Dr. Anupati.
Coming to the management part, on day 4, we continued the same treatment that we gave on day 1. We can see the treatment that we keep started. And along with we started carbimazole and beta blocker, that is on day 4, there was after giving this treatment, improvement in sleep was there, but other symptoms were still present. Now coming to the day 10, still suspicious behavior, judgment and insight improved. However, he continued to deny any physical or psychiatric illness, indicating that insight is still not intact. His BP was 130 by 80 millimeter per Hg. Heartbeat were 84, respiratory rate was 15, and temperature was 97 degree Fahrenheit, which was lesser than before. And patient was discharged on request and advised for follow-up at both psychiatric and endocrinology department. Mildly increased rate of speech was still there, but that was not pressured. He was calm, well-oriented, and conversing coherently without any delusion or bizarre behavior on discharge. So at the time of discharge, following treatment was given, sir: divalproex, quetiapine, lorazepam, carbimazole, and propranolol. We got the patient on first follow-up after 15 days of discharge. We reported 50 to 60% improvement. Physical symptoms of thyrotoxicosis and mania improved. Vitals were also stable. Improvement in insight and judgment could be seen. On second follow-up, after 45 days, there was 80 to 90% improvement, and patient was biochemically and clinically euthyroid. complete return to normal mental state corroborated by his attendant was there, and our plan was to taper psychotropic drugs and maintain the patient on minimal dose for at least 2 years. Sir, as we start the treatment, for any psychiatric problem, sir, treatments always take time, and we have to keep the patient on maintenance phase, sir. So generally, if one episode is there, sir, we keep the patient on at least for 2 years.
So at day 45, let me ask my physician colleague, particularly the residents, the patients come with fever and very severe sore throat and dysphagia. What would you think of? Anybody volunteers? No. अभी रुको तो तुम्हारा नंबर तुम्हारा पेपर पता है तुमको now just volunteer. What would you think of a patient on anti-thyroid medication, whole bunch of antipsychotic medications, comes with very severe sore throat, dysphagia, fever?
The only thing we advise patient to inform as soon as he is on anti-thyroid drug.
चलो आपको एक hint देते हैं. The leukocyte TLC was done because
I still remember one line from Goodman-Hillman Pharmacology that you should monitor every week CBC. Now, tell me what is your diagnosis? CBC to be repeated every week. This was long time back. What is that term?
What is happening? Carbamazole is doing.
Okay, what are the causes of agranulocytosis?
मेरे को तो ये बोलने ही नहीं देते कि अंकल से चुप रहो. Endocrinologist बोलेगा, physician बोलेगा, तो नहीं.
As Dr. Raman highlighted that earlier we used to go for weekly CBC exam testing, but now we are not doing it because we know that this agranulocytosis can occur anytime. So what we say is that if you are having fever and sore throat, please get a CBC and inform us. So that is how what we say to our patients to identify early agranulocytosis.
So let's come into our final diagnosis. That we made is bipolar affective disorder, current episode mania with psychotic features, Act 31.2 according to ICD, that was precipitated by hyperthyroidism.
What happened to the thyroid gland on the follow?
Sir, that was youth thyroid according to endocrinology department.
No radioactive iodine ablation?
No, sir.
Again, why is it not just thyrotoxicosis alone? Why do we have to get the bipolar disorder in? Once people were youth thyroid, I agree the argument that you have to use sedatives to quieten the patient in the initial phase. Day 45, the patient is quiet now. You are continuing anti-thyroid drugs. Why not consider withdrawing it and then be sure? Because once you label him as a bipolar, he is committed to lifelong treatment and follow-up for the bipolar disorder.
Yes, sir. Of course, sir, we could do this, sir. But as we have discussed already, there is a past history of hypomanic episode.
That is history. Now let's talk of this episode. See, that you can have various other explanations. That alone is not a gold standard point to decide that this is bipolar.
Sir, but the delusion of periodicity and level of periodicity and persecution we have seen, sir, that is very unlikely if it was only hyperthyroidism. So coming to the discussion part, thyrotoxicosis is an excess of thyroid hormone in bloodstream, is characterized by anxiety, fatigue, generalized weakness, insomnia, weight loss despite increased appetite, tremulousness, palpitations and increased perspiration. Before there were effective treatment for Graves' disease, thyrotoxicosis was associated with development of base dose psychosis, which was first described in 19th century. Neuropsychiatric symptoms such as manic excitement, delusions, hallucination and anxiety are very common among patients with thyroid disorders. In worldwide lifetime prevalence of bipolar disorder, according to World Mental Health Survey 2021, is 2.4%. According to study done by Radhakrishnan et al., patients with either schizophrenia or bipolar disorder showed that 3% of these patients already had thyrotoxicosis. Strikingly, suicidality was nearly 5 times more likely in patients diagnosed with hyperthyroidism than in patients who were never diagnosed with hyperthyroidism. These are the diagnostic criteria of mania. Mania is a distinct period of abnormally persistently elevated expansive or irritable mood lasting at least a week And during that period of mood disturbance, increased goal-directed activity of energy, inflated self-esteem or grandiosity, decreased need for sleep, more talkativeness or blood pressure, distractibility in flight of ideas are there. And patients who develop a true manic episode while thyrotoxic frequently have an underlying mood disorder or a family history of mood disorder. Clinical manifestation of hyperthyroidism are believed to be due to synergistic interaction between increased serum level of thyroid hormone and excessive catecholamine stimulation. Tyrosine, thyroid hormone are structurally similar to norepinephrine and dopamine, and hyperthyroidism increase the density and sensitivity of receptor in the brain, and overactivity of adrenergic system explain the similarity between clinical presentation of hyperthyroidism and mania, as well as precipitating role of hyperthyroidism in development of mania. Although the exact mechanism of behavioral disturbance in relation to thyrotoxicosis can be explained by overstimulation of hyperadrenergic system, thereby disrupting the adrenergic pathway between locus coeruleus and frontal lobe, which is responsible for attention and vigilance. Coming to the last slide, in our case, our patient experienced physical symptom of hyperthyroidism such as tachycardia, fine tremors, moist skin with concomitant manic symptom. It is unclear whether the resolution of patient's manic symptom occurred from treatment of thyrotoxicosis or treatment of mania, because both conditions were treated concurrently. Although there were no well-established guidelines for treatment of mania associated with thyrotoxicosis, some studies suggest that patients with this condition should first be treated by restoring them to euthyroid states. We presented this case because it is a very rare case that proper mania is there in thyrotoxicosis. And we are still working on the case on follow-up. That's why we haven't signed the case report for publication. And finally, the take-home message is it is imperative to both consider and exclude medical conditions that have direct pathophysiological consequences in psychiatric conditions. Thyroid disease can worsen or cause a variety of psychiatric symptoms, and thyrotoxicosis due to grave disease can mimic the signs and symptoms of mania. Treatment of underlying organic disorder, when we found, is recommended in management of psychiatric illness. However, it may be necessary to also utilize psychiatric medication to minimize concomitant symptoms. Yes, sir. Sir, he's coming on the follow-ups.
आपके पास पहले दिन से आया और अभी तक कितना समय हो?
Sir, around 6 months.
So I think as Dr. Kapoor said, this is not how you make a PowerPoint slide. You have to have bullet points and you don't have to have sentences. I don't know, आपके ज़माने में तो जो टेलीग्राम है वो तो खत्म ही हो गया है अभी, everything is WhatsApp and emails. पर जैसे टेलीग्राम पे आपको हर वर्ड के पैसे लगते थे, मालूम है आपको? तो फिर जो टेलीग्राफिक लैंग्वेज होती है, that is the kind of material you should have on this. And sir, may I request that we organize, your office organizes like presentation skills, like a short, and I think some of our residents need it.
We can do that 2-3 hour workshop, or I already requested if there is a slot which is going vacant for some reason, I can make a presentation on how to make a presentation.
So, do you have? So, any burning questions from Raju?
I like the statement that he was thinking that he is the chosen one. That is an absolutely right statement. You are the chosen one to perform the duty that you are doing. So do it well. You are really the chosen one.
Would you prescribe treatment for mania for Dr. Raju?
Good morning everyone and my respected teachers and colleagues. As we have discussed very nice case of Graves' disease, like I am nuclear medicine physician here, and the radioactive iodine treatment is nowadays very preferred modality. Most of the surgeons are here, but nowadays very few people will be doing, like maybe doing the thyroid surgery for Graves. And radioactive iodine, like in between we discussed that agranulocytosis, adverse effect of anti-thyroid drugs, like if patients have young patient without any other comorbidities also, like can receive radioactive iodine therapy. and it is very like cheaper compared to the surgery. Only 5,000 approx for 10 to 15 millicurie, which is required for the treatment. Exactly, sir. As I have joined recently, but 2-3 cases in a month we are doing, and it is very cheaper modality.
And the contributions from the endocrinology department.